time, I rechecked her inhalation technique and found that she got wrong inhalation technique. So we correct that. And after 1 year that she got control from her psychotic problem, her weight got lost and act control got better. But then other things gone like allergies attack and gastritis, which found out to be H. pylori. So we used the treatment of the allergies and the treatment of H. pylori. And then after we checked the technique, I moved her to the device of once daily dosing to improve the compliance. And after all, she got improvement in her lung function and ACT score, and then weight get lost because of improvement of the psychotic problem. Then I reduced the dose of omalizumab, and then we discussed about how does my sleep tablet, because her allergies come back now. And then she quite okay, but then another aggravation of her allergic rhinitis despite the treatment. So we started a sleep tablet. How does my immunotherapy? She got pruritus only, but it persists about 8 months, but she said it's okay, no need to addition any medication. So after 3 months after sleep, I reduced the omalizumab dose again. At that time, I prefer to minimize the cost, so I reduced again. And then her sinusitis attack, so I resumed to the 300 milligram every month. And then I increased the treatment of the allergies. And so finally, she got very stable. I choose this case because I call her. We use the telemed now. So the patient don't need to come to the office. I called her. We don't have the peak flow, but she very good now. She don't take any oral medication. She just was on 1 inhalation and 1 spray and just the tablet, which she take it every day. So I just a very good example of the case. And after 4 years that I saw her lung function, which was done last year, very good, and reversibility all gone. So I think I got 1 minute, so I can roughly go through the local side effects. This is the study of how does my sleep tablet, that would say about 25% of the patient had local reaction, but in my small number of series, we found like 50%, but they were mostly mild. And mostly asthma not seem to be had more local reaction than allergic rhinitis similar. So I think it's very safe for asthma. And I would go to pass this slide. And the local reaction that we would worry is about edema. So the one case that I show you, we have severe local reaction. So she got throat edema, like feeling like she cannot swallow anything at all for 3 hours. So then we move her to vestibular application. So then she got another ulceration that persists not only 1 month. In Thai population, we saw that the symptoms of local reaction could persist months, but mostly were mild. So just educate the patient. And if they got local reaction, I pre-medicate. So I was gonna end with the German recommendation of how to manage the local adverse reaction. So I use no pre-med at the first tablet, but if they are fine, they can go with no pre-med. But if they had some local reaction, then can have the pre-med at home. But if the local reaction with any systemic reaction or airway obstruction, then they need to be read pre-med and take it at the office again. And if they got another systemic reaction or still persisting moderate severe, then we discuss with the patient. For my patient, I use other application like vestibular. It's better for the throat swelling, but she got another side effect. But her risk factor is she got systemic reaction from subcutaneous before. So I'm gonna end my presentation from what I experienced about how does my sleep tablet in Thailand is effective and safe, despite I use it for my severe asthma patient. Very low risk of systemic reaction if you got very good risk stratification process. And what my key is, I stick to the criteria of evaluation. I use multidisciplinary team approach. I extensively search for the sinusitis, and I select only the patient with this disciplined patient. And if the patient had previous systemic from subcutaneous, we need to have close monitoring. And I inform everyone about local reaction and to insist to take the medication. But we still need more information about how to manage moderate to severe local reactions. So I'm gonna end my presentation.
Thank you very much, Dr. Ticha. I'm not so sure if there's time for Q&A with Dr. Ticha. Do we have any time for that? Serena?
We can allow what question?
Okay, do we have some questions for Professor Ticha from the audience? Okay, I have a question here. Could you please elaborate, Professor Ticha, on vestibular application of immunotherapy?
Yes, it's the off-label, actually. We cannot say that is the recommendation. Usually I ask the patient to take the tablet sublingual, but for this case, she got swelling of her frenulum, and she took photo for me that it got very swell. So we asked the Professor Ike, the one who done the clinical trial of how does my sleep tablet, and he said that some of his patients that had problem with sublingual administration, we could advise them to take it vestibular. It means the area how would say, in front of your gum, in front of your teeth. It's like in your buccal area. So I advise the patient to take in that area. That reduce the throat swelling, reduce the frenulum swelling. But from my patient, she got another thing like the local ulceration, Aptas ulcer, is different things. So I would say the vestibular application reduce the throat swelling. She tolerate better, but she cannot tolerate because the ulceration happens every time she took the tablet. So she moved to one side to another side, then the ulceration got, and then she come back to the same side. The old ulceration still there. So she cannot tolerate because the local ulceration. I'm not sure if that's clear for you.
Yes. Any more questions from the audience? I think that we have one more, Professor Ticha. What is your experience in Thailand on shifting from subcutaneous to sublingual immunotherapy?
So I had only one experience, which is not good because I select the one with systemic reaction from immunotherapy, from subcutaneous. But from other patients during the COVID, I send them to the local area. It means satellite hospital. We send our patient to everywhere. We give them with the vaccine and the lecture, but we not shift them to the sublingual immunotherapy right now because from my protocol, we need to do the spirometry everyone before starting the sublingual immunotherapy. So I'm not move anyone right now, and I do not initiate any new case of sublingual immunotherapy during this time, because if she had anything that would like to contact the hospital, it would not be a good period or moment, so I will postpone. But my experience from shifting subcutaneous to slit, I think it would be okay because we don't need to have the dose increment. We just had the same dose. But the thing is, the risk stratification had to be do again. No, they can fail subcutaneous not because of the medication, but because of comorbidity. So many patients come to me because they would like to shift subcutaneous to slit. I go through my risk stratification again. If the sinusitis and comorbidities get clear, I start with the sublingual immunotherapy, no problem.
Okay, I think there's one last question. Is the size of the skin prick test and level of IgE of the patient associated with the risk for side effects?
No, actually there is no association. Even asthma severity is not associated with the side effect. So we don't know who's gonna have the side effect. But I inform everyone about the local reaction. So some of the patient had just allergic rhinitis, but she got local reaction. But some with the multiple disease or more severe asthma or allergic rhinitis, some of them had no reaction at all. So it's not depend on the size of the skin prick test size or the specific IgE level or the severity of the asthma.
Okay, so I think that wraps up our session this evening. And I would like to thank our speakers, Professor Durham, all the way from London, and Professor Tisha from Thailand, for sharing their knowledge and experience about this type of treatment that is now in Asia Pacific. With this, all this knowledge, we may be more confident in trying to use immunotherapy. So I guess we would like to say goodbye, and we'd like to thank our sponsor, Abbott, for facilitating this discussion.
Ladies and gentlemen, distinguished guests, APEC Live webinar on allergen immunotherapy finishes here. We thank our today's chairman, Dr. Marisha Recto, and our two distinguished speakers, Professor Stephen Durham and Dr. Tisha, for their great contribution. We thank you all for your active contribution. We would like to invite you to our next live webinar series on learnings from COVID-19 frontiers related to safeguard and practice for HCPs, and on 37th of May, and also the COVID-19 in pediatric populations on June 2nd at 1 o'clock Singapore time. We also would like to have your support in filling the survey form, which you will see while leaving this webinar on your screen. Thank you very much, and see you back on May 27. Goodbye, everyone.